This is the Family Hour, empowering families one episode at a time. We are grateful that you are watching Church of Uganda Family TV. Thank you so much for making the right choice. Today is a Tuesday and we are here to discuss family health. Today we are looking at another very, very important topic, and I believe your life will not remain the same, especially after listening through today's discussion and probably the rest of this month. Edrine Osteen Mukalazi is my name, and today we are looking at the current status of HIV and AIDS situation in Uganda. But of course, as Church of Uganda Family TV, we are committed to working with like-minded organizations to restore hope in families through the power of media. That is why we are grateful to Uganda AIDS Commission and UNAIDS for the support they have offered. The whole of this month of November, we are with them. We are going to work together with Uganda AIDS Commission and in collaboration with UNAIDS. So we have a lot more. As we know that 1st December every year is the World AIDS Day. Therefore, it is important that we give attention to this disease, and it's the reason we are here. The whole of this month we are going to talk about a lot more that you need to know. Today we are looking at the current status. Of course, there are very many stories out there about certain districts and how the statistics are varying, so it is important that we follow through so that we can know where our stand is. We know still there is a vision that by 2030 at least something should be done, but is it visible? We are yet to know how that will happen. Of course, we also heard of an injection that is yet to be launched. We shall know how it will work. So one thing I can assure you is that all the questions you've been having are answered here. What you need to do is to tune in every day on Church of Uganda Family TV, Family Hour, as we dissect all these various, and we leverage the various topics concerning AIDS or HIV AIDS. But today we have Dr. Daniel Byamukama. He is the head of HIV prevention at Uganda AIDS Commission. Doctor, it's a pleasure having you this evening.
Thank you.
Yeah, kindly greet our viewers.
Good evening, viewers. Glad to be here to talk to you this evening.
We are glad to have you this evening. How is Uganda AIDS Commission?
We are at Uganda AIDS Commission.
Okay, that's interesting. And maybe just to know, because we hear about Uganda AIDS Commission, there is AIDS Information Center, there is TASO, the AIDS Support Organization. So someone would really want to know what is the jurisdiction of the commission independently of the other institutions.
Thank you. I think that is an important question. Because sometimes I travel and people ask me whether from AIDS Information Center. So Uganda AIDS Commission, number one, Uganda AIDS Commission is a government agency under the office of the president. TASO is a non-governmental organization.
Okay.
Started by people who were living with or affected, whose relatives who were affected by HIV. The same thing with AIDS Information Center. They are private sector or non-government organization. So that's a big difference.
Okay.
The Uganda AIDS Commission exists because when we started the national HIV response around 1986, it was mainly run as a medical response, as a health response, like a TB response, or like a cancer response. But it later became clear that the HIV epidemic was unique. It affected very many sectors, and the response depended on action beyond the health sector, significantly. So we started what we call a multi-sectoral response, multi-sector. So a multi-sector response means it recognizes that beyond the health sector, all other sectors will have a role to play. So we have guiding frameworks. So the Uganda AIDS Commission coordinates all the sectors beyond the health sector, including education, including private sector, including the media. Because I must tell you, the media has a key role to play. There are so many Ugandans in this country, dotted all over the country. We can't reach them. We are at the Uganda AIDS Commission, we're skeleton staff, not more than 50. We cannot reach every village. It is only through media that messages can quickly get through to the people. So the media plays a key role. So that is what I'm saying, it's multi-sectoral. We need the media. You cannot underestimate the role played by the media. The religious leaders, almost every Sunday, I would say more than 90% of Ugandans throughout the week have been face-to-face with the religious leader. So, and some of the determinants of HIV infections are within the mandate of the religious leader. It's the business of religious leader. So leaving out the religious leader, the religious community in the fight against HIV and leaving it to the doctors alone would have been unwise. So we came up with a multi-sectoral response. So what the Uganda AIDS Commission does, it coordinates to make sure all the key players, from the health doctors to the Ministry of Education, to the media, to the cultural leaders, to the religious leaders, to make sure we are all speaking one same language. Nobody is conflicting the other, nobody is contradicting the other, and nobody is forgetting to play their mandate. Because everybody, it's like carrying an elephant. Everybody is given a part where to lift. If you dare fail to lift your part, you will not take the elephant off the ground. So we are there to coordinate, to give feedback. You are the one letting the others down. You are part of the cake of the elephant is this. And we make sure we support now everybody to make sure they play their part well. And we work toward the same goal of ending the AIDS. As you said, we are committed to ending the AIDS epidemic by 2030. It's not just a dream.
Okay.
So when you speak about it next time, speak about it boldly, because don't miss words. We are committed to ending the AIDS epidemic, and that goal was launched by the President, His Excellency General Kaguta Museveni, in 2017. But I must remind you that since 1986, the President had always argued that the HIV epidemic is a simple epidemic. In his own words, he has always said, since it cannot be transmitted by mosquito, since it cannot be transmitted through handshake, most people who get it either must go through the labor of buying a hotel, you know, those things. He has always regarded it as a simple disease control. And when he launched the Presidential Fast Track Initiative in 2017, I think he was working on a dream, on a vision he has always had. And we totally believe, for us as the technical people, that we can end the AIDS epidemic by 2030. And I'm here to tell each one of us the part we can play. Because to end the AIDS epidemic, each one of us must play a part.
Exactly.
Which I'm here to, I hope I'll get the opportunity to really tell to every individual to
we
see
actually
what
start from there.
What part they can play.
It is important that we talk about that and complete it, because like you say, the role of the media, the role of the religious leaders, but someone else would say, I'm not in the media and I'm not a religious leader. So they would feel exempted from the fight, from the struggle. So let us talk about this fully.
You see, nobody is exempted from the fight against HIV, because we have a role to play as individuals. And this is where I want us to be clear. If we are going to end AIDS as a public health threat by 2030, everyone must play a role. If it's a person living with HIV, even if they are not a religious leader, they have a role to play by making sure they go to the hospital and get the free, effective medication we give. Taking medication now, we have discovered, it's one of the best prevention tools that we have in the country. If we could help all our persons living with HIV to take their medication well, or if they could accept and each one of them plays their part and take the medication as prescribed by the doctor, what does it mean? They will live a long, healthy life. What does it mean? They will not transmit HIV to anybody else. That is important news. But what is going to stop the people living with HIV from taking their medication? It is the fear of being shamed, of being judged. So that comes in another part that an individual can play. We play a part by making sure we don't shame We don't stigmatize. People we think are living with HIV. The stigma goes beyond even the individuals who think are living with HIV. It goes to the families. A brother of somebody who's HIV positive gets stigmatized. A daughter of somebody who is HIV positive gets stigmatized. But now that stigma, the pressure, and I must tell the listeners, there is pressure in evil things. The pressure of stigmatizing people, of making people feel less than you. You know, it's like human beings are always looking for an opportunity to feel superior, to feel more important than others. And you having an injury or having a disease in your body is a very good platform for somebody to laugh at you, to create a hierarchy and come on top. But the pressure of being on top costs us, because if we stigmatize the people who are living with HIV, it means they will not take their medication as the doctor prescribed. We miss out in the sense that if they are our relatives, they will most likely proceed and die, but they may transmit that HIV to another person, and it will go around and end up with your child. So as individuals, there is so much we can do, even if you are not a religious leader, to make sure we contribute to the fight against HIV. So I've mentioned too, the people living with HIV, taking their medication well, everybody else making sure they support them by making sure there's no stigma and discrimination, helping them. But there are so many numerous things, as we discuss, will show you that the highest new HIV infections we have in the country now are occurring among young women, adolescent girls, between the age of 15 and 24. What is the reason? 34% of all girls in Uganda, by the time they get to 18 years, they are married their wives, in spite of the law. You remember, I don't know whether you know somebody called Miriam Achebe.
Yes, I know.
So Miriam Achebe and her generation, they pushed for harsh laws to stop marrying off girls at a young age. So there are strong laws on the books that would land in prison if you married off a girl before they are 18. But I must tell you, under that law, we already have 34% of all girls. So, and they get married under the full view of the whole community, who know the law is being broken, but nobody really gives advice. And we have discovered that keeping girls in school to another level, even if they stayed another 2 years, even if you did anything small to encourage your neighbor's daughter to stay in school, to encourage a parent to keep their child in school, just by simple words of encouragement, you are saving so many new HIV infections. So the number of things we can do are numerous before we even ask the religious leader to stand up and preach. Because the other fact I must bring out is that we notice, I am happy I'm at Family TV. We notice that the greatest number of new HIV infections after the adolescent girls and young women. We may talk about them later again. But it is people who have failed in marriage. The second highest new HIV infection are occurring among formerly married women. So that means either divorced or separated or widowed, and formerly married men. So the church and the religious community has a role to play there, to support the families to avoid disintegration. And the disintegration of families partly explains why there are so many girls who are actually girls who have raised up, getting married, ending up in sex work, ending up in really painful circumstances that force them into decisions they make that lead them into HIV. So the church has a clear role to play. And if time allows, I think it will need a whole afternoon for me to come and discuss what the church can do for us. There are numerous things, but what we know is that every Ugandan meets the church. If it's not at a funeral, it's during the Sunday service or it's during fellowship. And everybody is really, we still have most Ugandans obedient to the religious leader. So the word spoken by the religious leader is law, and we're still counting on the religious leader to mainstream the HIV prevention message in whatever they do. We cannot, I've told you the staff at UAC were like 50, but we are counting on the multi-sector response that even the religious leader, wherever they are, they are going to take this message.
Yes.
It's a national message.
Yes.
The journalists yourselves, the moment you get your mic, if you have done your research during the day, really add in 1 or 2 words of HIV. Because if we don't give the people the message, somebody is busy spreading the false message.
Yeah.
That is the unfortunate part of nature. Somebody is wasting time crafting a misleading message that's going to mislead so many young girls into getting pregnant, into contracting HIV.
Yes.
So if we don't go out of our way and make sure the good message is outside there, the message that has helped us grow and even get jobs and not fall through the cracks, I think we are not playing our part very well. So the HIV response, as I said, is a multi-sector response. We are counting on every individual to use your office, to use your experience, to use whatever you have to contribute. Even if you are not going to contribute to the outside, on the outside world, you can contribute on yourself to make sure we defeat the AIDS epidemic by 2030. Okay,
Doctor, we want to look at the progress of the response from 1986 to date, because you've talked about the 34% of the young girls that have registered the newest infections. But let us talk about the general statistics and how the response has improved over the years, because we are almost getting closer to 2030.
Yeah, the response, I think, when we talk about ending AIDS as a public health threat,
yes,
the question I often get is, can we end it? Because somebody says, our people are on treatment.
Yes.
So ending AIDS, no, we shall not kill them. What it means, that means our people who are HIV positive will be living a normal, vibrant life with support of our treatment, highly effective treatment called antiretroviral drugs, and they will be healthy, living a normal life.
Yes.
And as I said earlier, if they are taking their medication well, they do not transmit any new HIV infection. So that means there will be nobody contracting HIV, but there will be nobody dying of AIDS-related illness. Last year alone, we had 52,000 new HIV infections, which are unacceptably very high new HIV infections. So, and in line with our goal of ending new HIV infections by 2030, it calls on us to accelerate, to put in some momentum.
Yeah.
And we notice now, even when I'm in the communities, when I was a young man, whenever I went to church or I went for a funeral, I found the religious leaders really talking about this disease. But these days, I think they have moved on to other things. Maybe because the funerals nowadays is cancer or something, because we started treatment. But in the spirit of the national commitment, would want to ask our religious leaders, we have less than 10 years, so don't get tired.
Yes.
If you really put in the effort like our religious leaders, our seniors put in the 90s, we can defeat this epidemic. Because it is defeatable, it is straightforward, the mathematics is clear. But it requires that we accelerate. The remaining 7 years, we accelerate. Everybody who has something to contribute, they pray it now. Otherwise, if we fail, I must tell you why the religious leaders must also now make that final effort now. The National HIV Treatment Program, which makes us proud, most of the money we use for treatment comes from donors. And that is where the challenge is. Because if we are getting most of the HIV treatment money from outside, do you think it is reasonable to continue adding on the number of people who are going to be coming for ARVs, which we are getting as a gift? No, it's not sustainable. In the long run,
and the donors have also
and the donors are threatening to getting tired.
Yes.
Are starting to getting tired. So in the long run, we shall be going to the hospital with malaria, but you'll find the line so long. Right now, we estimate we have around 1.45 million people living with HIV. Because of treatment, the number of people living with HIV every year has to increase, because there are new additions every year.
Yeah.
But because of treatment, the number increases. So we'll find if we don't work hard and end new HIV infections, maybe by the time it gets 2050, we'll be having long lines of people who are coming for regular HIV treatment and checkup. The people with malaria will have nowhere to sit. We don't want that situation. Besides, if the donors pull out, HIV treatment must be taken without missing. We don't want a situation where we go and we start scrambling for HIV treatment like we scramble for Panadol now. Because we don't have enough resources. So I have heard in the past, I regularly hear that young women nowadays boast that they fear pregnancy. They don't fear HIV. Now, that is a very wrong attitude. That is a lack of knowledge, a lack of understanding. Most of the HIV treatment that you're counting on is given to us a gift. So you cannot say you'll add yourself onto that. You will not increase the burden on the donor. It is unfair. I usually use an example. Imagine if you're paying school fees for a relative in the village. You're helping a relative in the village to buy him food and his family, to pay school fees for his children, and then you hear that he's planning to marry a second wife and a third wife and a fourth wife. He breaks you down. So for us as Ugandans, we have an obligation to make sure we really don't continue the spread of HIV by doing everything we can to prevent further HIV transmission or acquisition, so that our relatives who are already on HIV treatment, they are assured of the treatment. But if we become so many, every Ugandan on treatment, they don't have their side may also get tired and get stressed. And even our few relatives who are already on treatment may lose out this privilege. So let's do everything we can. And I will tell you, if time allows, what is it that we have in store for you that you can do to make sure
we shall have that
you
time.
Don't contract HIV.
We shall have that time. I assure you that. But let's take a short commercial break. When we return, we have a lot more to talk about, especially when it comes to the fight against HIV/AIDS in Uganda. Stick with us.
For God so loved the world that he gave his only Son, that whoever believes should not perish but have eternal life.
Because once Christ warns about something, it calls for attention as believers. When God warns us about something, it means that we are susceptible to it.
Finally, be strong in the Lord and in the strength of his might. Put on the whole armor of God, that you may be able to stand against the schemes of the devil.
This is Church of Uganda Family TV, enriching lives.
Welcome back from that commercial break. We are talking about the current status of HIV/AIDS in Uganda, and it is very important that you as an individual know your role. You might not be a victim today, but if you do not play your role well, then who knows what will happen tomorrow. So it is important that we all play our roles. As Doctor is really emphasizing, you might not be a religious leader, you might not be in the media, you might think you do not have a platform where to share, but that simple effort, or that a small effort that you put in, is part of the fight, so that by 2030, HIV/AIDS is no more in Uganda. It is what we are discussing. And before the break, Dr. Daniel, who is the head of HIV prevention at Uganda AIDS Commission, was telling us about the status, the current statistics. But Doctor, I want to look at of course, you talked about stigma, and I realize stigma is really one of those challenges, and I think partly the media has also been part of the stigma, because there is a way we tend, other media houses and not Church of Uganda Family TV, there is a way they tend to elevate someone's status, and there is a way I think partly that is a challenge that we have when you're talking about the role of the media. I remembered that sometimes we also forget our role, and we add on to the pains that the families have. But let us look at the challenges you encounter in this struggle that you are in. Yeah.
The challenges we face as the HIV, the leaders of the response.
Yes.
Of course, the first one is the one you've talked about, stigma. Stigma really breaks down our momentum. It dilutes our messages. And so would want, of course, stigma is, it comes from ignorance. Most people who are stigmatizing others are not aware that they are doing a painful thing to others. But we have come up with a policy, and a stigma policy with guidelines. So we are moving across the country to make sure we teach people how stigma looks like and how to stop it. We hope it will contribute greatly to ending stigma. I think the other challenge, of course, in addition to stigma, is that we have leaders, respectable people, either inadvertently or deliberately sabotaging our programs, evidence-based programs which have proven to work since the advent of the HIV epidemic. I can give you an example of a condom, very effective tool. If there are no condoms, you just see people sit there and lie and tell lies, and the bad-mouth condoms. But if there are no condoms, because the HIV treatment came just recently in 2002, since 1986, the best tool we had was either abstinence which can be done by not very many people, being faithful to your partner, which also fails very many people, and would say if you fail, use a condom. And I want to tell you, those who failed were very many. And the condom ensured that the generation did not get finished. But unfortunately, those generations, the survivor generations, the survivors, when they stand up to speak about the condom, they badmouth it. So for us, from the HIV response, and the condom was invented long ago, before even HIV, for family planning.
Oh.
Yes, of course.
Okay.
The condom program in Uganda is as old as before independence.
Okay.
So, for family planning, so we would say, let us, if you must make a contribution, don't make a contribution by negating our efforts, by sabotaging effective national programs, which are part of national policy. Example is a condom program. If you really, within your beliefs and values, cannot support a condom, at least don't badmouth the condom. It has saved so many. And we're counting on it, because for us in the public health response, we study the behaviors of our people, of the population. Not everybody can be saved by the same tool. As I said, a few will manage abstinence. Not very many can manage abstinence. A few will manage being faithful to their single partner. If you're faithful, you are likely to have that your partner is equally faithful. But others will be saved by other tools. And now these are the tools which are often inadvertently or intentionally sabotaged. But we would want to call on all leaders where you are to exercise your authority, really, your power carefully. Don't sabotage. The more you sabotage our programs, the more you put people at risk, because there are people who will not use the tools which work for you. There are people who will only be saved by condom. So if you cannot support the condom, at least don't sabotage it. Don't mouth it. By the time us, the scientists, have put it out there, we have done the due diligence to know that it's good for our population. So don't mouth it. At least keep quiet. We have programs like circumcision. I must tell you that we recently did a new survey, a national survey, from Kotido to Kabali, from Mbarara to Mbare, everywhere, and interviewed people and tested them for HIV in their homes, in the communities. So we have a national sample. We discovered that actually the greatest number of people still contracting HIV now, of men. The HIV prevalence in Uganda is higher in women than men, almost double. But the men who are still contracting HIV are the uncircumcised men. So we did it in research long ago, and we came up with a program to circumcise at least 80% of all sexually active men between the age of 15 and 49. And we started rolling out this program. But here and there, you get a political leader, a religious leader. This is an evidence-based program, advanced by religious Ugandans with the same values as you have, raised in the same community, under the same values. But because they have evaluated the community, we are able to analyze our communities to know that not everybody will be saved by abstinence. So those who cannot afford to abstain, we shall give them something. And we must make that service available for them. So like circumcision, we would want men to circumcise, because the data is clear at population level that men who are not circumcising are being left behind. They are the ones still contracting HIV, and they're the ones still transmitting HIV. So we would want to see that here I'm referring to sabotage of programs and the inadequate political will. We appreciate our president, General Museveni. He's really a key leader. He has championed the national HIV response. But we would want to see his efforts replicated at various levels of leadership. So you get a president who is advocating for HIV prevention, pushing hard to make sure HIV gets audience, gets on the agenda. But you get leaders who are supposed to magnify his message, who are supposed to act on his message, really dismissing, it's sabotaging our efforts. So, but we want to call upon all leaders, religious, cultural, political, who would want to work with you, with the championship of the president, to make sure we implement the tools we have. Because when the president came to launch the presidential fast track, to make a commitment, to commit the country to end AIDS by 2030, it was not air. The president doesn't, you cannot move him to make decisions hastily. No, he first asks you questions. You must bring the mathematics and put down the science. And then he will say, okay, I am not going to lie. And then he launched. So when we launched, we were counting on all these tools. So a religious leader who stands there because he hates a condom and starts bad-mouthing a condom, you are negating on the national commitment. If you don't like the condom, it's better really you keep quiet about it and let those people who can be saved by a condom be saved by it. We have seen religious leaders who preach and dispense miracles. I must have forgotten to tell you that last year we had 17,000 people dying of HIV-related illness. That is still unacceptable because we have enough medication, and our medication is now convenient, easy to take. It's unlike the medicine of long ago. So there's essentially no Ugandan should be dying of AIDS now. But 17,000, those are so many Ugandans who have died. You know, Nyankule would say, they shouldn't have died. So, but we know part of the reasons why we have people dying of AIDS now, number one, of course, is stigma. Number two, the mushrooming religious leaders dispensing miracle cures. Totally dispense casually, and they ask you to abandon your airways. So we really would want to work with you closely to make sure if really a miracle is there, The miracle can come and we verify it before you ask somebody to stop. We verify it through lab tests and say, okay, the miracle happened. Because, but don't encourage our people. When you're doing miracles, I don't think it's very good to try out HIV. But let's work hand in hand. In case there is a miracle, we can help you verify it. And even publish it in books for everybody to know about the miracles you do. But don't let young men and women abandon their medication and proceed to die because you really of the miracle. So those are, but of course the other key challenge that we have in the response is the one I talked about of resources. That is key challenge. So in the response we need leadership. We are proud of the leadership we are getting from the chief, the head of set, but we would want that leadership among all the key gatekeepers at all levels, religious, cultural, political, at all levels. And now at the various levels below the top, we have some components there, but we would want everybody mobilized. So money, resources for the HIV response remains our key challenge, and we believe HIV mainstreaming is going to be our solution because there are no donors who can give us more money. Yet, as I've shown you, the number of people contracting HIV is still unacceptably high. As much as we are reducing for the last 3 years, we notice that we have stagnated. We are not doing much achievement. We have stayed above 50,000, praying around 52,000, 53, 52, 51, 54. So that calls for greater momentum, calls for greater resources, but we cannot get additional money. It will be very difficult. So we are calling on leaders, yes, we are continuing to ask for more money from our members of parliament if we are to deliver on the promise of ending AIDS by 2030, which is doable. But we are calling on what we call mainstreaming. So mainstreaming means that in your workplace, where you are, you appreciate that because people are congregated at this workplace, there is a risk to them of contracting or transmitting HIV for your own staff. So you start by putting in place methods to save your staff. But mainstreaming also means that because you have so many staff here and so many people who come to interact with them, their risk and vulnerability is increased. So you must come up with initiatives that go beyond caring for your staff. So in your routine work, can you find an opportunity to prevent HIV? And there are so many that do not require an additional budget. And if you invited me, you're not going to pay me for coming here. I ask you to invite me all the time. If there is an opportunity, I ask all the media houses, invite us to use the opportunity to deliver the message to your people, to your audience. If I deliver this message, maybe somebody outside there who would have come and picked on your staff and transmitted HIV to them may get the message, and your staff will indirectly end up benefiting. So we are counting on every institution within the country. You can come in consultation with the Uganda AIDS Commission, and we shall guide you at no extra cost on how you can mainstream HIV within your institution to make sure you use every available opportunity at no additional cost to pass on the message of HIV prevention and control, to do activities that support the fight against HIV, so that every institution and every individual in this country plays a part in contributing to ending the epidemic by 2030 at no extra cost. Otherwise, if we are going to sit and say, okay, here is our bill, we do not think the government of Uganda can afford the amount of money we need, because a significant amount of money is from donors who are running away, and yet the shortfall is significant. What needs to be done is so much, but through mainstreaming, everybody, consider it like corporate social responsibility. Everybody being guided on identifying opportunities within their routine work to advance HIV prevention and control for their own staff and for their clients. That we are glad we can easily come in as UAC and help you with mainstreaming. And this mainstreaming, we want it done from national to village level. So even the village circle, we would help you to mainstream HIV in your routine work, and you make your contribution at no extra cost. So those are the key challenges that we we face in the HIV response, but the other challenges are several. There are so many granular small challenges, I can list. If you go to Chiriandongo, they will tell you a different kind of set of challenges. They'll tell you the fishermen on the lake are so mobile. They disappear. Once we have started on treatment, then the fish moves and they go. So the challenges are quite several, but the key ones at the top level really rotate around political leadership that we need, the resources we need. The resources will help us to implement all the programs we need on scale enough. I can give you an example of a good program. You talked about in the introduction about an injection. So, of all the assortment of tools that we have, that we are counting on to help us end the epidemic by 2030, there is one new tool. It's called pre-exposure prophylaxis. What that means is that if you are...
Is that what we commonly call PEP?
No, it's different from PEP. This is called PrEP.
PrEP. Actually, I think that it's also important as we talk about this, that we draw, because now there is PrEP, there is PEP, and now there is the injection you're talking about. I think let's talk about these three and draw a difference.
So, PrEP, let me start with PrEP, like the one you used to go for in high school, going to study at night. That's the same spelling. So PrEP, what it means, it is pre-exposure prophylaxis. What it means that people who are HIV negative, I told you earlier, regularly we study the population in Uganda. We can categorize the behaviors of Ugandans and know that these ones are at high risk of contracting HIV. If they don't have HIV this year, it's a matter of how soon they will contract if they stay in this behavior. So that people, we recommend that they use what we call pre-exposure prophylaxis. They are not yet infected with HIV, but they will be given a medication which is in the form of antiretroviral therapy. They start taking. So right now we have two modes of pre-exposure prophylaxis. The first one is in the form of pills. Take a pill every day. But we have discovered that program of pre-exposure prophylaxis using pills has been running for quite some time, more than 5 years. And we have discovered that people who are not yet in pain are very difficult to motivate to stay on the pill. So many drop, many don't adhere properly. But we have a new invention, which we believe will add momentum to the response. It is called injectable long-acting PrEP. It is still a form of pre-exposure. It is antiretroviral therapy. It is given to people who are HIV negative before they're infected with HIV to prevent them from acquiring HIV. One injection, 3 milliliters every 2 months. You walk into the hospital, the nurse gives you an injection, you walk out and get on your boda in your car and go away. So we believe, where we have done research, women found it very convenient. Because you will notice that most of the other modes of HIV prevention that we have are convenient for men. Including condoms, most of them are for men. Circumcision, men. Even women, when we give them oral PrEP, the husband starts harassing them.
And questioning.
Are you promiscuous? Are you doubting yourself for doubting me? You know, those conversations come up and the women end up abandoning. And then they end up finding the HIV positive. So we want something that is discreet for somebody, a young person. Imagine a young person who is sexually active, but has a big sister or an auntie she stays with. If she comes home with a tin of pills called oral PrEP, she'll be harassed, she'll be questioned, she'll be done. So, but this injection is discreet. You visit the hospital once in 2 months. So these small problems, or I didn't have transport, we minimize them. And these violence, problems of violence and the cultural issues you overcome. So believe, and I must be clear, these pre-exposure prophylaxis, both the injectable and the oral, are not for everybody. They are for that population group where I tell you we have studied and we discovered that the way they live it is not a matter of whether they will contract HIV. It's a matter of how soon will they contract HIV. So now that we already have studied and seen that our own brothers and sisters within Uganda, within our community, we can easily locate them.
Yeah.
If they give me money enough, I can have a congregation of all the people whose behavior will most likely lead them to contracting HIV without fail. I know them, I know where they are. So we would want them to access this PrEP. So I want to use this opportunity. Because when we told people, including religious leaders, that there are sections in our society, people with no parents, people who are already drunkards or something,
Yes.
the ones you have failed to really minister in the village and convert them. So those ones, we cannot let them die. Or we cannot let them contract HIV because it's very expensive to put them on long-term treatment. Or if they contract, they also transmit.
Yeah.
So those ones, we need to give them pre-exposure prophylaxis. But I have heard that a few religious leaders, when they heard about it, even political leaders, they said now this PrEP, it is promoting promiscuity. It is not true. Because during the research to come up with this pre-exposure prophylaxis, one other component of the study was to establish whether people given this PrEP become promiscuous. Promiscuity is dependent on so many other things. Having the money to buy the lodge, having the money for transport, having the money for all those things. But we discovered, and how did we monitor? We monitored the prevalence of other sexually transmitted infection. So once people become loose and become promiscuous, they will get other sexually transmitted infections like chlamydia, like gonorrhea. So we monitored. What did we discover? We discovered that indeed people who are on pre-exposure prophylaxis, both the oral tablet or the injectable, they are not more promiscuous than the general population. So that anxiety or that debate or that excuse to sabotage our program, I want to really preempt it now. Don't make an effort. The pre-exposure prophylaxis, both the oral and the injectable, are for categories of the population who are at very high risk. That does not include your daughter and your wife or your son. But there are categories in the community there. The ones who don't even come to church. Or the ones who come to church and you wish you would change but you have failed to change. Let them access this PrEP. They're also good children. So don't sabotage that program. It does not promote promiscuity.
Doctor, briefly as we wind up, then how does PEP work? Because that was
So PEP is another key part of our program. Because the evil in the community, which the religious leaders are always trying to fight, but they have never finished.
And
There is evil. They may never finish it. People go around raping people, raping young women. Doctors, while they're working in the hospital, they get accidental injuries. There are so many accidental exposures. I've gotten young men calling me left and right and saying, okay, the condom. I discover now many people don't know how to use the condom because the condom message has died out. The people who used to educate the community about condom use are no longer doing it. And it used to be the community leaders themselves. So because of such, we have a pill in form of antiretroviral drugs given to people who have been accidentally exposed to HIV. You're HIV negative, but on your way home from work, a man raped you. We would want every young woman. Partly, the reason why there are so many HIV infections is because there is a high prevalence of violence against women. So we would not want to get any young woman contracting HIV because of violence. It's not your fault. So we would want you to go to the nearest health center that offers HIV treatment after you've been violated through sexual violence, accidental exposure, through these border crashes and whatnot, where you think you've been exposed. The health worker will evaluate you and tell you there is a risk that you've been exposed. And if there's a risk that you've been exposed to an HIV infection, they will give you treatment. If you arrive within 72 hours, they will give you treatment which is effective in helping you to not to contract HIV. That treatment you take for 1 month. But unfortunately, so many of our sisters and daughters are getting raped across the country. and they are not accessing this medication. So I would want the religious leaders to take this message. It does not promote promiscuity. Research has been done to answer that question, but to help us stem the so many new HIV infections which are not sustainable, because as a country we cannot put every Ugandan on HIV treatment. We can't afford it.
Okay. Doctor, in a minute or less, what are your closing remarks on today's discussion?
My closing remarks is that we have so much we have done in terms of research. We are having our National HIV/AIDS Symposium. It is going to be at Kororo Ceremonial Grounds from 14th to 16th. It is open to the public. This month, November. We would want the community to come and interact with the scientists, and you ask them all the questions that you wish you would have asked me today. It is a public scientist and community meeting. We shall be showing off the tools we have, and you will be choosing what is good for you. So I'm inviting you to come and join us, all of you, even those who can't speak English. Come to the Kororo Ceremonial Grounds between 14th and 15th. We shall be celebrating Fire Retire Memorial Day. So we shall have some entertainment, some educative music inspired by the Fire Retire Memorial. But we shall answer all your questions and mobilize you to join hands with the scientists to make sure together we march to end AIDS by 2030.
Thank you so much, Dr. Daniel. And the message has been clear. Let each of us play their role. And with that, I believe we shall have an HIV/AIDS-free Uganda. And AIDS will be history, as Uganda AIDS Commission assures us that by 2030, if we all play our part, it will be history. I want to remind you that the whole of this month of November, we are focusing on HIV and AIDS in the family health episode. So we are in collaboration with Uganda AIDS Commission and UNAIDS. So all you have to do is to get your remote, tune in Church of Uganda Family TV. We have a lot more for you. God bless you. We meet again tomorrow as we discuss finances.